Hi, this is Irma Jennings, health coach and osteoporosis patient navigator. Kindly do me a favor. Subscribe to my YouTube channel. This way, the information will get out and circulate to more people, and that's important. Like the this YouTube with a thumbs up and comment. All these things will help circulate this information so more and more people can hear it. Thank you so much for your efforts. Hello, everybody. We're here. It's the Bones Tribe, and we're here with Dr. McCormick, and we're going to be talking about bone turnover markers, and who knows what's going to come up. But Dr. McCormick has been just so deeply embedded in the world of osteoporosis and knows so much and experiences so much. And every time I'm on a call with him and a client, it always amazes me the nuances of which he looks at things and says, "Oh, wait a minute, what about, look at this, ferritin." Seems to be the latest hot topic these days, ferritin. But anyway, so let's talk about bone turnover markers. What are they? Why doesn't everybody do them? Um, and take it from there. How about that? You want to go that way?
Me, me.
Yeah, I don't want to talk about it.
Before we get started, I want to make sure everybody knows that this is just for information, educational purposes only. So that's a great question. Why doesn't everybody do this? And I think the reason, well, one of the reasons why is because if you don't do them properly, then you get all kinds of crazy results, and it doesn't make sense to the doctor then. They do it, but they don't know that they have to do like the CTX, especially the telopeptide, the bone resorption marker, that's a reflection of osteoclastic activity. They don't realize that you have to do it first thing in the morning, and fasting. And the reason why is because telopeptide can vary by 200 points or so throughout the day. It's the highest at 3 in the morning. It's at the lowest at 3 in the afternoon. So even just doing it from between, like 8 or 10 o'clock in the morning can vary a lot. So they might do it twice in a person and get 200 points different, and they go, well, this isn't any good. This doesn't make any sense. So I think that's one of the reasons why. And also you have to obviously not obviously, but you shouldn't do biotin or take biotin or supplemental collagen for 2 days before. And if you do this correctly, if you stick by that all the time, then you start getting more reliable results and they make more sense. But even doing it that way, you know, it changes. These things are run on circadian rhythms, and so even as we get lighter and lighter in the morning, and in the winter it's darker, that's going to change the time too. So uh, whether you do it in the summer versus January, it's going to make a difference, and it's hard to keep all that straight. And so you do the best you can, but when you do one day and then the person says, I don't believe it. And so we repeat it in 1 week and we get 75 points difference. That's the way it is on the C-telopeptide. P1 and P is not the same, is not that way. It'll vary 5 or 10 points maybe, but the CTX can, in some people, vary like 75 points. So I think that's one of the reasons why doctors uh, don't do them. They also don't know what they are a lot of the times, and they just don't want to bother with it. Most endocrinologists are just wanting to say, "Hey, you got a T-score of -3.5. Take this medication, and I'll see you in a year or two." They don't want to bother with it. So I think they're the couple of reasons why they don't do it.
So going back to a point that you made, so are you saying that in the summertime, when the sun is rising at a different hour versus the winter, that it's not about the time of the day, it's just about
Not about the time, it's a circadian rhythm. We have rhythms that are run on the chiasmic, the super chiasmic nuclei in the brain, and that has a lot to do with the light that's coming into your eye. There's special um, receptors in your eye that get your circadian rhythm going. And when those photoreceptors are stimulated, then your body starts waking up. And when they're not stimulated and it's 7 o'clock in the wintertime, then your body's going to be different. So yeah.
Okay, so then this is not on the same thread, but are you a believer to sit outside in the morning and as the sun is rising to reset the circadian rhythm in the body? Do you agree with that?
Yeah, I think that's a good idea. Yeah. Yeah.
Do you do it? You
I
don't do
don't know. It's too cold out there in the wintertime.
it. Okay, so that's the CTX. If anybody has any question about the CTX or anything that we're talking about, raise your hand and we'll take advantage of this time with Dr. McCormick. So how often should one do the CTX?
All depends on what you're doing. If you monitor CTX when you're monitoring resorption and a an anti-resorptive medication like a bisphosphonate or Prolia. If you're monitoring an anabolic like Forteo, Tymlos, or Evenity, you'd be looking at P1NP. And but you always get baselines before you do anything. And if you're trying to figure out estrogen levels and how estrogen is doing with the osteoclast, you might be doing it every 3 months. If you're pretty stable and you're no longer on a medication or you never were, but your bone density is pretty good, your CTX seems like it always comes back at 300 or so, then you probably do it every year. So there's so many different, reasons to do them or not do them. And I think, I was talking to my son in Hanoi, and we were talking about how the whole world is going with AI and the whole world is going with programs of, sliding people into these programs that are kind of set and there's not a lot of really looking at the exact moment and all the different parameters that are going on and then making a decision. It's like, it's like, okay, every year you get your CTX, your P1NP, or whatever, whatever, whatever. Well, so often that's just wasting money. Maybe we need the P1NP, maybe we don't. Maybe we need the CTX, maybe we don't. But let's look at what I like to do is look at the situation for what it is today and in 3 months or 6 months or whatever, and then decide then what to do and when to do. And I guess I'm a little upset with how a lot of you know people who work in the osteoporosis field are doing things. They're just doing it by like a mechanical kind of thing. So uh,
I remember we were having this conversation about precision medicine with that gentleman that presented at the Integrative Healthcare Symposium. I forget his name, but I remember that he did 200 push-ups before he came up on stage, and he's 87. And he was talking precision, precision, precision. And then you said to me, but Irma, that's what we do. And that's the point that you're making, is that you look at the individual person, not just the bones. You're looking at the whole body, which is the first book that you wrote. And that makes such a big difference because everybody can do one thing. Oh, I'm getting these particular tests and everything looks good until all of a sudden there's a magnifying glass with Dr. McCormick that says, no, 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 this is off. And this could be, skinny fat, or this could be whatever it is, some of the terminology that you throw around. That's like, wow, it's deep. It's deep.
I
Okay.
always tell people about the story. I had this patient, and when I was still doing chiropractic, and he was having all this rib pain or it was pain in the front here, and it wasn't midline, but it was pretty close to midline. And he had 5 endoscopies, three from one hospital, one from another hospital, and another from another hospital. So three hospitals, five different endoscopies. And I'm going, Leo, you know, and did they find anything? Well, no. And I go, well, why do they keep doing endoscopies? Well, I kept having this pain. And so they just did endoscopies. And I said, but when you went to the other hospital, didn't that hospital look at your three they had at the first hospital? And they thought they'd do their own endoscopy. It's like nobody came up with anything. I mean, thousands and thousands of dollars. And so I'm a chiropractor. And so I looked at them and examined them, and it was a rib that was out of place. It was giving them pain right here, but it was a rib in the back. And so for $40, I fixed them, in one treatment, and his pain completely went away. And he'd spent, I don't know, thousands and thousands of dollars to get these endoscopies. And so it's not only that I think there's poor medicine out there, but people just do kind of the same thing, no matter if it's done before, they don't even look at the records. So look at the records, see what's been done, and if it doesn't need to be done again, don't do it.
Agreed. Let's go back to basics and talk about anti-resorptive and resorptive. Can you just put that into simple terms?
So an anti-resorptive medication is when you're decreasing the osteoclast. So the osteoclasts break down bone, they resorb bone. So an anti-resorptive is something that takes that resorption away, that slows down osteoclastic activity. And that's the five, typically that's, if you look at the medications, that's the 4-bisphosphonates and Prolia. They are the anti-resorptive drugs. So they shut down osteoclastic activity. They don't kill the osteoclast, but they certainly incapacitate the osteoclast, and at least the bisphosphonates do. And the Prolia is an antibody against this thing called rankle, and that's a transcription factor that promotes osteoclastic activity. So that just takes that rankle away, and so therefore there's no stimulation of those clasts to break down bone. But it's an anti-resorptive medication, but it's very different than the bisphosphonates. Acts very different. But they're your five really anti-resorptives. But you could also consider, I guess, the SERMs, the selective estrogen receptor modulators, like residronate, like raloxifene, and because that's calming down those osteoclasts. So that's an anti-resorptive. And then the anabolics are the three, Forteo, Tymlos, and Evenity, because they are, well, Evenity isn't it, but the Forteo and the Tymlos are stimulating those osteoblasts to make bone, and so they are anabolic. Anabolic is building up, catabolic is tearing down. So these are building up bone. That's why they're building up tissue and bone density. So that's the big difference between the anti-resorptives and the anabolics. The anti-resorptives just build bone and just build bone density. They're just causing more hardening of the bone, more calcium deposition into the bone. And the anabolics are actually building bone matrix, collagen matrix, and then allowing the calcium to impregnate that collagen and make it harder. But it's actually a bone quality, a bone tissue that's being formed in addition to the density.
I've had this ongoing conversation with a client whose doctors insist her to continue with her Fosamax. She's at the 5-year mark, and they want her to stay on it longer. And so what do you think about longer than 5 years on?
I don't like longer than 3 years, but so I think, bisphosphonates are fine, and they certainly calm down those clasts and they preserve bone. They build a little bit of bone density, but in the long run, in the short run, I think they're great. They certainly have their place. All these medications have their place.
Mhm.
It's just that when they're used unwisely, then it's a problem. But when you keep doing a bisphosphonate or Prolia, um, you never have bone turnover happening. You never have all of osteoclastic and blastic activity is dropped down, and so the bone gets old because every day, all day long, when you walk around, when you lift things, when you whatever, you're incurring microfractures in your skeleton. And those microfractures have to be culled out by bone remodeling. And that's the action of osteoclastic activity, tearing down the cracks, the microfractures, and the blasts coming in and forming new bone. So if we don't have that bone remodeling constantly going on, you're going to get an accrual of microfractures. So if we're doing it for a year or 2 years, even 3 years is okay. But now you're starting to get into 4 and 5 years, you're starting to get a buildup of these microfractures. And so your bone gets uh, less strong because of the microfractures.
Okay, thank you for that. So just going back, and then we'll answer a couple of questions. Um, if one is just monitoring their CTX because they're doing weight training and diet and lifestyle changes and gut health, how often should they get that test done?
The CTX, sorry.
Yeah. Hmm. Yeah.
I mean, I would do it certainly every year.
Hmm.
Um, But as I said before, sometimes, especially if we don't know if you're stable or not, then every 6 months, or if you're testing out a medication, maybe every 3 months, but usually at least every year. I wouldn't not do it every year because you don't know what's going to happen. I mean, certain things happen. Like I've had people uh, they weren't gluten sensitive and then they became gluten sensitive, or they didn't have Lyme disease and now they have Lyme disease, or they didn't have a gastrointestinal issue and now they have a gastrointestinal issue, or we're always changing, and so it just, it's better to see a change, a future change in your bone before it happens. And that is, you don't wait every 2 years to get a bone density. You do bone turnover markers, and then you can say, wow, that's a little weird. My CTX just went up to 500. That's a problem. Let's figure out what's going on. It was always a 300 before. What's going on? It's also a good idea, especially because fractures. If you have a really low bone density, and even if you're stable, well, geez, if you're always at 300 and then all of a sudden you get an 800 or 1,000, you might think, well, maybe I had a silent compression fracture. So silent compression fractures can increase that CTX and P1 and P because your body is healing that fracture. So it's a nice sign for that too. I mean, uh, there's just lots of reasons to keep doing them.
So to keep doing them and to track them and to do it at the same lab, same time of the day, idea, yeah, yeah. And that's an interesting tracking on its own because you can be like me that just shows up. I don't make a reservation because that's just my personality. But yeah, I always seem to get in, but sometimes it's 7:30, sometimes it's 8, but just to make a
If
note.
it's within a half an hour, that's fine. I would rather people not even get it at 7 o'clock sometimes and 8:30 other times. I'd rather, try to get within half an hour. And I know that's hard, or an hour, I guess, at max, but
But not impossible. Okay. So let's go to the P1NP because questions are piling up. And so some people, some doctors only, they don't want to do the P1NP, they do the bone-specific alkaline phosphatase. Can you look at that and say, well, if they decide not to do that, so a patient comes to you, they can't get the P1NP, they live in New Jersey or whatever, so they can't get the test themselves, but the doctor will do the bone-specific alkaline phosphatase. Do you use that in lieu of the P1NP or not really?
it's different. So I had a woman today and she had that problem.
Mhm.
and she had two issues. She had thalassemia and she had hypophosphatasia. Uh, and because of that, she didn't have alkaline phosphatase in her body. I mean, she had a little bit, but hypophosphatasia is a condition with very, very low alkaline phosphatase. And her doctor would only do a BSAP, a bone-specific alk phos. Well, that's going to be low. It's not going to do us any good. Um, it's at a different stage in the bone formation than the P1NP is. So the the alkaline phosphatase, the bone-specific alk phosphatase, is when your osteoblasts are, you know, making this enzyme to start the bone formation process. The
Mhm.
P1P is actually, well, the collagen has already been made, and now we're lopping off one end of the collagen molecule and measuring that. So it's at a different time, different stage in the bone formation process. So uh, um, I guess it's like saying, well, the milkman's here. That's great. And then the milkman left, but he didn't leave the milk, you know? So things aren't good here. I'm not going to have my breakfast. So even though the milkman came, so I don't know. I just came on a
That's a
fly,
good
on
analogy.
a fly with that. That was good, huh?
That's good. That's good. And of course, it's milk, so it all relates to calcium. So, and what about a very, very low P1NP? What does that indicate to you?
Um, well, bone formation is your anabolic part of you. So it's uh, you know, poor anabolic capacity. And maybe it can be because you need you need so many factors to build that bone. So, um, you need your muscles uh, to tell your bone that they're needed. So testosterone, low testosterone. You need um, uh, protein to make the bone. You need the collagen. So there's all the different factors of collagen, like iron. When people are anemic, they don't have the iron in their body, and iron is is a really, really important factor in making collagen. So, I mean, there's so many reasons why a P1NP can be low. So we're always looking for things like that. Even cell membrane integrity is important. So you look at maybe factors that have to do with cell membrane integrity. Um, yeah, so many things. So if somebody's really, I have this patient in New York, and she has a really low both CTX and P1NP, and like 12, and
12 with the P1NP?
yeah, yeah, and 140 for the CTX, and she's 50 years old. Well, it shouldn't be that way. She has what's called adynamic bone. It's there's not, there's nothing happening in her bone. Uh, Aluminum toxicity can cause that. So, I mean, it's really endless. There's so many things that can do this, and typically, the endocrinologist is going to look at it and they go, well, I don't know, let's give them bisphosphonate. That's instead of trying to figure out what's going on. So,
Because A, they don't have the time, and maybe they don't have the, I don't want to say the
but they should
experience.
have the expertise. I just think they don't
Yeah,
have the
it's the
time. I
time.
don't.
Yeah. Or they're not putting all of those pieces together as far as the complex. I don't want to badmouth endocrinologists or rheumatologists.
But I
All
don't know. But it's right. I don't know why. I don't understand it. To me, it's such a fascinating exploration to figure this out. It was not only important for that person, it's their life, it's their, it's their happiness. So it's really important to do, but it's also incredibly fascinating to me, and to look at all these pathways that can happen. It's just like being a detective, and so.
Yeah, I think that you summed it up just right there, being a detective. Karen, did you have a question? You have your hand up. You're so patient.
I do, yeah. Thank you for being here, Dr. McCormick. I wanted to circle back to X. Um, at one point in time, you had mentioned if when we're monitoring medication like reclass, that it would be advisable to use CTX as a guide for whether another infusion might be needed, as opposed to that 1 year rule, that they
Don't,
seem to.
yeah, I always say don't follow that 1 year rule. There's so many people that it lasts for a year and a half, 2 years, maybe 2.5 years. So yeah.
So what would be the a reasonable normal threshold, or what end of that CTX threshold would you say, if you're beyond this
Yeah,
point,
that's
then
a
you
great,
might
great,
consider?
that's a great question. And it's a little complicated because did that person get a baseline before anything happened? If that baseline was an 800, the number is going to be different than if their baseline was a 450 or a 400, So, uh, you know, if their baseline was an 800 or 1,000, and we do it at one year, we do it at 3 months after they do their infusion, and it comes back 125, and then we do it at the 1 year mark, and it's a 325. I'm going to say do it. You know, uh,
Okay.
if their baseline was a 450, and we do it at 1 year, and so you do it. You do the reclass at 3 months. We do it. It's a 125. Then at 1 year, it's a well, it won't be a 325. It would probably be a 275 maybe or something like that. Then I'd wait. And then
Okay.
at 18 months I do it, and let's say it's a 325. I probably still wouldn't do it, even at 1.5 years, because their baseline was 450. So, I'd say, well, just to be safe, let's do it at 21 months instead of waiting to 24 months. So we'd play with it like that. And then once it
Okay.
gets to be on that person 350, then I'd say, yeah, let's do it. So
Okay. Because I'm approaching that 1 year mark, when we're going to measure the CTX, coming up on the
good.
1 year. So yeah, I just wanted. So you had mentioned in order to prep properly for the CTX, no biotin, no collagen for the 48 hours prior. It does the heavy lifting in the Anero program have any
Yeah.
impact on that?
Yeah, I wouldn't do a big heavy lift the day before.
Okay.
Yeah.
Okay. All right. Great. Thank you.
Everybody has a different opinion about the length of time. Some say 3 days, no heavy lifting.
I don't know that. I would say just one day would be fine, but
Yeah.
so that would be so whoever you heard say that, have they done markers like for 3 days after that, or because that's what we need to do, have somebody fork out the money to do 4 days CTXs in a row, lift heavy, and see how long it takes to get back to the normal.
And
You want me to do that?
yeah. Okay. No, well, I thought you said you had somebody that did that.
No, 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 no.
Oh, okay, okay,
Thought
okay.
you were
No.
putting that job on me.
Okay, yeah, why don't you do it? You have connections, you have weights. If you have celiac, and this is coming from the group here. So there's a celiac issue. She was exposed to gluten. She was going to have her bone markers done. The cramping is coming around with the not knowing that there was gluten there. How long should she wait before she gets her test done? the CTX or the P1NP.
So you're saying that
She had a flare. There was hidden gluten.
because some gluten snuck in.
Yeah, she has celiac. Gluten snuck in, and that happens. It's a bear. It's just so tough when you go out to dinner.
Boy, that is such a great question. I had this kid once, and I mean, if he just ate a piece of dextrose, I mean, that was made from wheat, I mean, it would set him off for 5 weeks, and I mean, I guess it depends on two things, and I'm just winging this, so I don't really know. But number one, uh, what was this person's response when they were eating gluten with their CTX and P1NP, and then when they went off of gluten, what's their CTX and P1NP? How much did it drop that CTX? Did it help a lot, or did it not help at all? Because I have lots of people who, their antibodies are high. And I think, oh, great, your CTX is 500. We can get you off of gluten. We're going to test you again, and it didn't do anything. The CTX is still 500, so it didn't change the person's CTX. So
But that was a celiac person, or that was a
no,
sensitive,
it wasn't celiac. It was just antibodies.
sensitive.
So,
So
but I'm just saying, I'm probably if there's celiac. See, I mean, celiac causes bone loss for two reasons, not for one reason, not just because of the antibodies, but it causes, celiac causes a disruption of the absorption capacity of the gut. So that's why their bone density goes down. But it also causes an increase in the antibodies, and those antibodies, anti-gliadin antibodies, IgG, IgA, the anti-tissue transglutaminase, IgA, IgG, all those things are antibodies. They're increased antibodies. It's the immune system raising its activity level, stimulating the osteoclasts, because the osteoclasts are a form of a white blood cell. So they are part of the immune system. So when they hear the noise of all these antibodies rising, they're going to increase their activity level and break down more bone, because that's all they do. So that's like I said, there's two reasons why in a celiac person that happens. In a person with not celiac, but they're sensitive to gluten and they just have high antibodies, then we don't have a disruption of absorption issue. We just have the antibodies. And how much of those antibodies do you need? The rise in antibodies, how much of that rise in the immune system do you need to then stimulate those osteoclasts to break down bone and change the CTX? Different on everybody.
yeah, so
So in answer to your question, I don't know, maybe 2 months if she had a really big flare.
mhm. So there were a couple of things that were packaged in there that was so dense, just as far as celiac versus gluten intolerance. And well, I'll just take a personal experience. I was diagnosed with C. diff with Dr. McCormick. I had something came into my life, and my CTX shut up, and I was inflamed, and I had to calm it all down, and it did. I don't know why it happened, how I got it. I don't know if it was actually C. diff, because we were talking about some of the qualifications of C. difficile, but clearly I was having a gut issue, and I was testing my CTX, and it got up to high 600s, and then it started coming down with some probiotics and a
You know,
regimen.
do you remember how long that took to bring
It
it
didn't
down?
take all that long. I was very
It
surprised.
didn't.
Did not. It took like 3 months, maybe. So Lori is asking, has her hand raised. Hi, Lori.
Hi there. The topic right before this last topic about celiac, you were talking about when the CTX, depending on somebody, maybe they had a 450, they had gone down, maybe they had reclassed, then maybe you waited, and maybe when they got to like 350, they could get another infusion. That might have taken like maybe up to even 21 months or something. But how many of those reclass infusions would you give a person before stopping?
It all depends, I guess, on the space between them. So I wouldn't do more than 3 infusions in a row. So each year, 3 would be my max. But if you're, doing them every 2 years, and we're just striking out and not being able to keep that CTX down, then maybe that's all we can do is, every 2 years, and we might do endless. I've never had anybody
Oh,
like that, but if there's nothing else to do and an anabolic's out for some reason and we don't want to do Prolia and we're stuck at a 600 and we can't figure this out, then just keep going. But
keep
I,
going.
and I've never had anybody like that, so I don't really know, but I guess that would be my answer to you. If you're doing it every year, 3 would be my max, and uh, yeah.
But to keep monitoring it.
Just see
And,
if
and,
you
and
want it.
don't these drugs stay in your body for a
And they
long
do,
time?
and usually with the zoledronic acid with the reclass, by the time you get to that third infusion after 1 year, you built up this, and so it will last for longer than that. So
So
it,
sometimes it can last for 5 years or something, or can't it? Like once you've sort of
um,
built it up and or not.
guess not 5, but certainly 3,
Okay.
3.5, maybe. I'm not sure 5.
Okay.
It stays in your body for 5 to 10 years, but
Uh-huh.
the effectiveness of it.
Oh,
So,
gotcha. Okay. Thank you.
because you always hear that on the internet, oh, this stays in your bones for 10 years. Yeah, it does, but it's not effective. It's
Ah,
such a low dose. So,
ah,
Oh, that's a
there's
good
a
good.
to
low
know.
amount, so.
So Nancy was asking, how is Avinity different from Forteo and Timlos? So those are the anabolics, the
Yeah, I had kind
anti-inflammatory.
of alluded to that, 20 minutes ago, and then I didn't keep going. So the Forteo and Timlos stimulate, and the Evenity allows. So
Allows?
allows, right? So Forteo and Timlos stimulate those osteoblast cells to form bone. And Evenity is an antibody against sclerostin. And sclerostin is a protein produced by your osteocytes. So you have 3 bone cells, osteocytes, osteoclasts, and osteoblast. And the osteocytes are kind of like the governor. They kind of oversee what's happening with the blast and the clast. And they say, I don't want this person to have osteopetrosis. So osteoporosis is a thinning of bones, a low bone density, but osteopetrosis is too much bone. It's your bones have gone crazy and they've gotten way too active, forming too much bone. And we don't want that either. It makes, bone really heavy and really brittle. So your osteocytes produces sclerostin to keep the osteoblast in check. They're saying, okay, this sclerostin makes it so the blast calms down their bone building action after a certain point. And the Evenity is an antibody against that sclerostin, so it takes that sclerostin away, and so therefore we don't have this braking mechanism of the blast. So it's allowing the blast to go rock and roll as much as they want. And the reason why Evenity is a biphasic drug is because, in other words, it's anabolic for the first 6 months and anti-resorptive for the last 6 months or thereabouts, um, is because the blasts kind of peter out and they say, okay, well, you've allowed me to build all this bone, but now I'm tired and I'm going to rest. So it's allowing versus stimulating.
Hence the word allow. I see. Okay. Is that clear, Nancy?
Yes, thank you, Dr. McCormick. Thank you.
Have you been noticing, Dr. McCormick? Well, let me ask you a different kind of a question. People come to you because they want to look at the whole body and examine the whole body. And how many, in general, I know this is a broad question, how many of your patients are you finding important to go on medication? I know you have a process that they first come, they see you, and you say, well, let's work on this, increase your protein, get better sleep. You do the whole body thing, come back, let's check it again. And then slowly things are changing or not, and come back. And so in general, are you finding that more and more people eventually have to be on medication?
I guess if they're less than -3, if they're, -2.5, -2.8, something like that, -3.0, even -3.1, something like that. Usually, I mean, depending on the situation, usually I wouldn't jump at a drug, even though it's osteoporosis. But I would say the majority of my patients are, -3.5, -4, -4.5, -5, so um, those are, medication.
Okay. Anybody else have any questions? Now's the time. Don't be shy, because I'll make up some stuff.
I have one question. If if I if I had it to do over, and I'd like your thoughts on this theory of mine, but if I had it to do over, I might have delayed taking the teriparatide for a year until, if the Onera program had been available at the time I was making my decision to start the medication. Redoing it now, I might have waited a year to do Onero to see if that had an impact prior to taking medication. What are your thoughts about that approach?
I don't think it gives you enough that you're going to see it that big of a difference on the bone density. So I don't think you messed up in that way.
Okay.
You know, the thing I like about, whether it's teriparatide or abloparatide, is when you do Onero or any weightlifting program at the same time, I really think it kicks it in even more. It really capitalizes on the benefits of that stimulation that's happening from the medication. And now, so it's like saying to the bone, okay, we're going to stimulate you, but then the bone says, yeah, but you're sitting on the couch. So mixed messages here. You don't really need, you're stimulating me, but you don't really need me. But now if you need them, if you push it with your narrow, the only thing is you have to be a little careful because the first 3 months you're on the Forteo or Tymlos, I do think you're a slightly increased risk for fracture. So that first 3 months on one of those, not on Evenity, but on the parathyroid analogs, because it's stimulating blastic activity and they stimulate the class. And so all of bone remodeling is increasing and we don't have fresh new bone being built yet. It's being built, but it's not mature. So we don't have that maturity of bone and we have a rise in the clastic and blastic activity. So that's why the first 2 or 3 months, you're a little more at risk for fracture. So Evenity is not that way.
Okay.
It stimulates that, the blastic activity and doesn't bring up the clastic activity. So we don't have that same 3 months of danger. So
Okay. All right.
Well, that was a
Thank you.
really important question, Karen, because there's so often that people second guess decisions. Not to say that you were doing that, but there might have been a little bit of that. Maybe I should have waited. And I thought, boy, that was a really clear answer, Dr. McCormick, because it's a big decision. It's a big decision to go with.
dude, there's so much that goes into this whole game and it matters, how it's so.
Yeah. Laura, you have your hand up again.
Hi again. Dr. McCormick, I kind of remember you saying that some anabolics were better for spine. Some of them you'd have to watch out for cortical bone. Could you sort of, in just me in particular, I had a forearm scan. So I was just wondering, why did we do that again? And could you give me clearer and tell me again, what was the thought process with cortical trabecular anabolics better for one and why are they like that? Why is something better for a spine? Because I guess because it's better with building up the trabecular bone. But anyway, if you could clarify that.
So parathormone from the parathyroid glands is destructive to cortical bone. I should know exactly why that is, but I don't. Off the top of my head, I probably know it at one time, but I don't. And these parathyroid analogs, Forteo and Tymlos, they are mimicking parathormone. So they also are not great to cortical bone. They cause what's called cortical porosity, which is just what it means. What it sounds like. It's punching holes in your cortical bone, making the cortical bone weaker. And that's fine if you don't have a lot of cortical bone, like in the spine. There's only 40% cortical bone. There's 60% trabecular bone, because the Forteo and Tymlos do great at forming trabecular bone, but they punch holes in the cortical bone. But the overall effect is it really does improve that spine really a lot. The hips are 50-50, 50% cortical, 50% trabecular, and that's why you don't usually see a huge benefit from Forteo or Tymlos on the hip. You see some benefit, but not a huge. It's just so much better in the spine. But the forearm is 80 to 100% cortical bone, so we don't get anything really in that. And sometimes, and I've seen people's bone density go from a -2 to a -4 by the end of that 2 years on the Forteo, or Tymlos. But
And
the difference between them is Tymlos causes a little bit less of that cortical porosity than Forteo, and that's one of the reasons why I usually like to recommend Tymlos instead of the Forteo. But there's other reasons too, like that you can titrate the Tymlos and you don't have to refrigerate it, and so yeah.
and doesn't DEXA look at cortical?
Doesn't what?
Doesn't the DEXA scan look at the cortical bone?
It looks at every bone. I mean, it doesn't differentiate whether
So
it's cortical or trabecular.
it does, I mean, so if you have like a low spine, then you go on Tymlos and it will show better numbers for your spine, even though it might have
It might
made
have it might have hurt the cortical bone a little bit, but because it's just so robust of a response on the trabecular bone, it doesn't matter.
somehow it can, the DEXA scan can see that it's better.
Yeah, like I said, it's not, the DEXA isn't differentiating between the cortical bone and trabecular bone. Bone to a DEXA is bone. A DEXA is a measure of, so your body's laying here. Up here is where the X-rays come out. They go through you, and at the bottom the X-rays are caught, and it's what's called attenuation. You're seeing how much of those X-rays are being blocked by the bone, whether it's cortical or trabecular. The body doesn't differentiate that. So
Oh, and so when you have a TBS score, it,
well, the
that,
TBS
what does
is
that do?
all that's a computer analysis. It's called uh, a gray pixel analysis of that DEXA scan. So it's just looking for the connectivity of those trabecula. So if the trabecula inside the bone, that's where the trabecular, little struts and bars are. If they're connected, great. We got a great TBS. We got a 1.38 or something like that. If they're disconnected, and that's what it's doing, it's seeing how many are disconnected. They're like if they're disconnected, we don't get strength from it, and it's calculating that, and then we get a 1.1 or something on the TBS. So.
Does a TBS score usually go up when you've been on Tymlos or Forteo?
Definitely, yeah.
Okay.
Yeah.
Thank you.
And then to that point, if you have if you have an outer shell, the density of the bone, I'm just going to put it in simple terms, the outer part of the bone looks okay on the DEXA, but you're older and you probably have osteoarthritis, but the TBS is showing weakness. That's an overarching concern about the strength of the spine.
So are you asking if there's arthritis? Yeah, say that a different way, because
Okay, so if the density is showing a strong density like -2, but yet the trabecular bone score is 1.2, 1.1, is that is that a flag for you that says, oh, there's something going on in this picture here?
it's a little odd. I would say if that's true, then yeah, they have arthritis. That's what you're asking. So I would say there's probably a lot of spurs there, and that's making that look like it's a -2, like it's good, good
Right,
density. But it's
right.
because they have some sclerosing there, some arthritis in the facet joints and the spurs coming off of there or something like that. Yeah, and that's exactly why what's the statistic? 50% of women that fractured don't have osteoporosis. It's because we got that arthritis there. So, but it's you're kind of asking a really important question here that I don't know the answer, and that is why is why does that happen? Is that TBS being bastardized by that osteoarthritis? And now it shouldn't be. We shouldn't have that, change of a really good looking TBS if we have a lot of arthritis there, but we really have low bone density. But I think there is, and that's the REM people's complaint for DEXAs. They're saying that even that TBS isn't valid because we got the arthritis in there. But I don't know how much, but I see that once in a while where they have arthritis, they've had fractures maybe, and we got a TBS that's okay, but there's a lot of arthritis, and that doesn't make any sense.
Yeah,
So
but I think I was going the other way, that the bone density looks good, but the TBS looks bad.
I know, but the reason why the bone density looks good is because there's arthritis there. It's not
Right.
really good.
Right. But isn't that a flag when you see the TBS
I'm
is
sure.
okay.
Yeah.
Okay.
Yeah.
So how can you find out if you have a microfracture? There's no pain or other discomfort. Is it just height loss or
I guarantee you have microfractures, whoever asked that. Everybody has microfractures. I have microfractures. Irma, you have microfractures.
I don't. I don't.
Whether, yes, you do. But is the question, how do you tell if you have a compression fracture if you don't have any pain? X-rays.
How many people do you see that have a compression fracture that don't have pain?
It's pretty often. It's more often than you would think.
But which is really revealing because you're going through life and you think everything's okay, and all of a sudden there's a
Yeah.
compression, and you think everything is fine, and you're doing your stuff, and yeah.
And that's
Does
why the VFAs are good to get. If the doc
VFA, can you explain that?
and VFAs are not they're not infallible. I've seen fractures where VFA is normal. So a VFA is called a vertebral fracture assessment, and it's great because it's given at some DEXA centers, some DEXA facilities, and it's a X-ray, but it's very low radiation, but it's not really good quality. It's not, you can't rely on it to pick up all the fractures, but it's a nice screening for fractures that are there that you don't even know about. So,
Okay. This is something that we had discussed previously, you and I, with a client, as far as long-term use of Prolia. Prolonged Prolia equals brittle bones. Is there any way to counter that if having to stay on Prolia, they cannot take bisphosphonates because of an allergic reaction to that? Have you seen or heard of anything magical that?
well, if it's short term, you could, if it was only, one time, then maybe you could do raloxifene, the serum, to get them off. Bit
So
of
that's a Vista. That's something that's new Barb. That's something that's a new terminology, doing the Avista. Is that what you're saying, Dr.
Yeah,
McCormick?
right. So you could try that. And, if you only did one Prolia, then that would probably work. But if you've done 5, 6, 7, 8 Prolias, and you can't do a bisphosphonate, that's a problem.
Is Avista discontinued?
No. Huh?
I don't know why Dr. Fishman said that, Sheila, because I had not heard that. But so Dr. Fishman said that he thought Avista was discontinued, Dr. Lauren Fishman.
I have some patients on it. Huh? Not that maybe I don't know that. Punch it into AI.
So, here's the problem with that. Because people are doing that without really understanding all the ramifications that can come from simply, let me put it into AI, which I think
I put in this question a couple weeks ago, and it gave me the exact opposite of what was reality and of what was true. I couldn't believe it. I read it like 3 times as I kept thinking, it can't be that wrong, but it was. It was exactly opposite of wrong of what the real research shows.
So the assumption that AI has the ultimate answer is we're not there yet. I had put in, because I'm on prednisone and I have to have a tooth extracted, and I said, can I use any kind of antibiotic with prednisone? They're like, oh no, no, you can't use this and this and this. I was like, okay, all right. I went to my rheumatologist, like, no, that's not true. So yeah, so that you just have to be careful, and you have to go to doctors and get real answers versus making assumptions that it's right. Okay, last question. Have you seen people gain bone just from hormones?
Yes.
Like -3?
Yes.
So we're talking about.
But I always tell people, don't expect it. Expect it to stabilize. And then if we get some, we get some. That's great. But no. Yeah.
What's the oldest age, patient-wise, that you have that's taking hormones?
I think I have an 80-year-old, maybe 75. But I think if I have this one woman, she's 80, 81, she's taken.
And
But she's been on it for a
she
long
start?
time.
She's been on it for a while? Okay. Anybody else have a last-minute question that they want to ask? Because this is such a golden opportunity.
I think all this is just so fascinating, and I love it. And yeah.
That's really true. I mean, the more complicated the situation, the more jazzed up Dr. McCormick gets. I mean, I heard him the other day. He was talking about this ferritin thing. It was like, wow. I mean, it was more intoxicating to me to hear the enthusiasm of like, this could be an information piece that's so critical that's been ignored. And that's the kind of stuff that I think is really so important. So thank you very much for your time, Dr. McCormick. It was great. Can someone over 80 take hormones?
Well, I wouldn't start at 80. No. I would say no to that.
Okay. So I want to say thank you, everybody, for coming. This was a lovely turnout for the Bones Tribe. And thank you for being a member of my Bones Tribe and for trusting me and for Dr. McCormick's trust. So that's it.
Good night,
Thank you.
everybody. Thanks for
Thank
joining.
you.